Okay, ladies and gentlemen, good afternoon. Welcome back. Did you all have a nice lunch? Yes? Nice sirloin steak and chips and everything? Or was it a cheese sandwich? Right. Okay, we're going to crack on because we've got a really interesting afternoon, back-to-back interesting sessions. We're going to find out what was quite interesting, I thought, in the sessions we did this morning. We were talking about integrated care organisations, and of course we talked about health and we talked about local government and all that kind of stuff. But actually really important is the environment within which we live. So we're going to talk about now, I've got a big session. I'm going to allow the chairman to introduce herself and her team, and we're going to have 45 minutes discussion on the importance of the built environment in healthcare, and it is very important. Madam Chairman, over to you.
Can you hear me? Yes. Okay, good. Well, it's nice to see all these faces. Thank you so much for coming out today. This session was titled Improving Health Through the Built Environment and Seizing the Opportunity for Impact. So that's what we're going to be talking about. My name is Clare Delmar. I work in the healthcare space for about 15 years, both in providing healthcare services to hospitals, but also providing clinical services to patients. However, my background is as an urban planner, and I got into healthcare by building PFI hospitals, if any of you around here remember that. Yeah. Yes. But by way of introduction, all of us along this panel really work at the interface of the built environment, healthcare, and clinical work. And we're here because we actually believe that this is an important vehicle to help the integrated care boards, which is part of the organizations that are being addressed here, but also generally people and communities and neighborhoods to thrive. All of us come from different disciplines, and I'm going to introduce everybody in a second, but we're here very much because part of the mission of the way the NHS is now organized through these things called integrated care boards is to work with local communities, both individuals and institutions. And so we're here to discuss how we can improve the conditions for them to thrive. I also want to point out that there's been an acceleration of evidence over the last few years on the codependency between the built environment and health equity and public health generally. And it's manifesting increasingly at both the national level and at the local level. And just to give you a few examples, any of you who saw the Chief Medical Officer, Chris Whitty's annual report, which I think came out 2 weeks ago, which was all about health in an aging society, will note out of those several hundred pages, there was a good lump dedicated to the built environment and how that supports health and prosperity in an aging society. So at a national level, this is being discussed. At a local level, I don't think anybody in this room will not have seen how not looking at good health can really impact a local community. I noted with some consternation, last week I got something from the from the BMA, Scotland. So this is the British Medical Association, their Scotland branch, where they have had so much problem with local housing developments, putting too much demand on local GP services and not having planned for that in advance, that they actually have come out with a policy proposal to insist that developers fund GP surgeries. So whether or not that's a good idea is something we'll probably flesh out. But it's something that's happening a lot at the local level. So we believe that integrated care boards as a new format have a unique and timely opportunity to embed this evidence into good practice and create a new and sustainable approach to improving health and health equity in local communities by working with developers of the built environment. And with that, I'm going to introduce our panelists. So to my left is Lisa Finley. Yes, Lisa Finley. Lisa is a group leader and a partner at Heatherwick Studios. Then we have Pete Gladwell, hand up. And Pete is a director of social impact at Legal & General Group. And then we have Magali Thompson. Magali has a wonderful job title. She is the project lead for placemaking at the Great Ormond Street Hospital. So this is clearly an organization that sees the value of placemaking. We have Natasha Reed, who is the founder of an architecture practice called Matter Space Soul. And then finally, Michael Chang on the end. Michael is the program manager for planning and health within the Office for Health Improvement and Disparities at the Department of Health. So welcome, all of you. Thank you very much for joining me today. I'm going to ask each panelist to give us a very short, emphasis on brief, statement on what they think is a single intervention via the built environment that would improve overall good health, but also the functioning and the success and effectiveness of the integrated care board. So I'm just going to go from my left and we can continue on. So I'm going to start with you, Magali, and I'll pass you the microphone.
Thank you, Claire. So in terms of a single intervention, I think I would say, certainly for the NHS, that we need to start looking beyond our red line boundaries. And I think many descriptions of NHS estates focus on buildings and utilisation and capacity and building condition, but there's not that much talk about the spaces in between the buildings, how you travel to the buildings, the potential to partner with neighbouring institutions, and the significant opportunities to create health. I think that there are beyond your red line boundary, if you like, in terms of improving air quality, reducing exposure to pollution, and incorporating climate resilient measures. So in terms of a short and sweet suggestion, that would be what I do, look beyond your red line boundary.
Great, thank you. So can we move on to Pete, please? Can you give us yours?
Sure. So I work, as Claire was saying, I work for Legal & General, which is the UK's largest pension fund. And I think one of the main priorities for us is how we steward people's pensions and savings and invest them back into places that improve their lives. We think that's what people want us to do with their pensions and savings fundamentally. And so what does that look like? Well, it's using the right type of investment. I think a lot of the time we found historically the built environment has been created by very short-term capital, particularly developers who don't have the right type of investment. So they're not focused on long-term sustainability and creating places that are going to thrive in the longer term. So one of the things we're trying to do is bring longer-term finance, including LNGs, but there are others, to fund more houses and mixed-use schemes around the UK, mixed-use communities around the UK. We've done about 15,000 homes in the last 3 years, but a lot of this is how we can take that further to bring more of the right type of investment in. The second one is that stewardship angle, because when you're looking over the longer term, then that enables the curation of a place rather than just knock it out, build some homes and then move on. It's that long-term curation. That's good for us commercially because it generates more income to pay pensions, also enables us to create healthier places. And the last one, if I was going to leave one challenge for the NHS particularly, it's around the role of key worker accommodation. We see huge demand for that around the country, and it's actually something that's a really good investment for a pension fund. It doesn't make a quick buck. It generates really long-term stable income. So there are pension funds who want to help produce more key worker accommodation at more affordable rents, which would enable the NHS to attract and retain more of the right kind of staff. I think it's also, finally, just to finish off, economic benefits to that as well, because every home created gets more sites built and generates benefits that way as well. So key worker accommodation would be the one I'd leave you with, and welcome further conversation.
Great, thanks, Pete. Lisa, what about you?
So I'm coming at this from a perspective of an architect working a lot in cities and thinking about urban regeneration, and in particular the sort of revival of high streets. And I sort of feel a focus on health, and in particular health creation, could be an incredible catalyst to revitalise high streets. And I think there should be a kind of space for health on every high street in the UK. And integrated care boards could be a really great sort of core tenet of that space. They don't need to be the face of it, but I think the public should understand what this new creation is, who they are, what they do. It's incredibly relevant to everyone. And by being a sort of anchor in a space for health on high streets, they can also help facilitate community organisations, voluntary organisations, to have more of a presence on the high street and really promote health-creating activities.
Thanks. Natasha?
So like Lisa, my sort of background is in architecture, but my focus is very much on how we can put health and well-being really at the heart of how places are made, and developing new approaches, but also structured approaches to make this very much the mainstream, as it's not at all the norm in terms of development, and how we can make that an everyday reality. So something I've been working on is a new model. It's called the Place Quality Model, and that's been recently adopted by the Borough of Brent in London. And that's essentially completely changing the way that places are designed and assessed for planning permission to be about the impacts for people's health and quality of life. And that spans across quite a few factors, whether it's physical health, mental health, social connection, so tackling loneliness, how to build community, and also going into things like inclusivity and addressing different people's needs, like older people, children, and women. So I think having a really structured sort of model that we can agree on and say this is the way to do it would be really helpful to support ICBs in their mission.
Great, thanks. And last but not least, Michael, can you give us your thoughts?
Thank you. So I'm Michael Chang. I'm a town planner working in a public health setting, as Claire introduced me earlier. So my work, I work in the housing planning environments for health team within the Department of Health and Social Care. So we do have other things other than just the NHS concerns. So that's one thing to say. I think as a town planner working in a public health setting, when you hear senior public health leaders say, and I quote, more has been done for public health by proper planning, proper engineering, proper built environments than any other interventions, perhaps other than vaccinations. And you can come and see me afterwards to see who actually said that. Then you begin to think about how important my role is as a town planner working in a public health setting. So my kind of provocation really in this introduction is about regulation, to regulate or not regulate. And I guess my premise is planning for health outcomes doesn't happen by default. So therefore, you have to be very, very explicit about who you're planning for and who you are planning your housing developments for. And therefore, the kind of proposition is, do we regulate ICBs and the ICSs a bit more around this agenda, or we'll leave it to you and others, the developers, to build the housing that we think we need in this country? So I guess my kind of overall assumption is that we all have a responsibility around this particular agenda, whether you are working the ICB, the public health teams, or developers, or whatever it may be. And therefore, being very, very explicit about the way that you plan for health in your regulatory frameworks is really quite important. And so maybe there is a role for regulation, soft regulation, very, very strong regulation. I leave it to you to discuss. But I always imagine that because of the way that we have seen poor quality housing built in this country, primarily poor to mediocre, maybe it's time that we think about the role of regulation in building the standards that we need for good housing. If you've seen Downton Abbey, I think there's a quote in one of the last episodes, we can't get an A1 population from C3 housing, and it's similar to that kind of analogy. We had to build A1 housing for A1 healthy population. Thank you.
Thanks, Michael. So now what we're going to do is we're going to talk about a number of topics that have come out of what each of the panelists have suggested, and eventually get all of you involved if you have some questions. But I'm going to start off with a pretty fundamental question, which is, when you try to integrate health into planning, I'm sure everybody in this room would know what a NIMBY is. Put your hand up if you don't know what a NIMBY is, because a NIMBY is a person who advocates not in my backyard, as opposed to a YIMBY that advocates yes in my backyard. But like a lot of things in our world, it's a very polarized sort of group structure that tends to be generated in planning applications. And I have a belief that if there's one thing that everybody cares about, it's their health. And when a new road or a new housing development or a new commercial development is being proposed, it's a very fundamental question to ask, how is it going to impact my health? And isn't that an opportunity to converse harmoniously and peacefully? So I want to put it to the panel, how do we think that health is something that should be integrated into the planning process as a community engagement vehicle? So not as a kind of add-on that says, here's the health report, but is it so fundamental that it really should be part of the community engagement process? And I'm going to start with Michael, because Michael has done a lot of research on what we call health impact assessments. So we'll move on from there.
I would say yes. A lot of it is actually not about building into existing frameworks or systems or policies. We already have the policies, at least in England, to say you have to think about health with at least health needs. The JSNA, the Joint Health and Wellbeing strategy, and the planning policies that we make, in local government. So it's already been there since 2012. And my research have found that, about only a quarter of local authorities think about health needs and the health priorities in their long-term strategy. So in a way, we may not need more regulation. It's about upskilling people, understanding what actually what you do has an impact on everything else. And actually the NHS or actually ICBs have a legal role in the planning system. Unlike public health, we don't have a role in the legal planning system. And so therefore, use your leverage with your town planners in local governments to build health into those new developments, whether it be housing, commercial, industrial, whatever it may be, build them into that process.
And I'd like to ask Natasha, because she's been involved recently with a real-life example of this in the London Borough of Brent. And maybe you can just make a few comments about how, by integrating health and well-being, this has actually brought more of the local residents to support some of the planning proposals?
Yeah, well, the idea with the work that I've been doing in this new framework is that it can be used as a tool for communities to actually set out what are their needs, what are their priorities, what are their aspirations, and have that way of shaping what gets sort of put forward as the development. But it starts from what they've set out, and whether it's they need safer places, or they want, they don't know their neighbours, or just lack of green space, that sort of thing. So then there's a way to take what the community's needs are and put that into a set of sort of guiding principles for either a development, a whole neighbourhood, or a place. And then it really reflects, what is unique to those people and what are the issues. So I think using sort of health as the way to bring the community's needs into development is really powerful.
So, I mean, it takes two to tango when we create places and big infrastructure projects. And I guess I'd like to move a little bit beyond how the local authority looks at health, or doesn't look at health, as the case may be, and ask the question, how do we inspire developers of the built environment, commercial developers, about local health? How do we actually bring that into the design, planning, and development process? And I'm going to ask Lisa and Pete to comment on that, if I could, maybe starting with Lisa.
So I suppose one aspect is trying to, sometimes when you mention the word health, different connotations come into mind, and it's a sort of, it might be about fitness, or it might be about just not being ill. And I think one of the big conversations that could really help developers get excited and get really sort of on board with this lens of looking at design and the built outcome is really the idea of health and all of the social determinants of health. What is it about everyday living that it really means health? It's the idea of being able to bump into somebody. It's the idea of being able to see activity on the street. It's, feeling safe late at night. It's not just, a sort of technological requirement. And so really, designers being able to communicate that understanding of health, not a sort of very kind of typical notion of health, if that makes sense, I think would make a really big difference. And I know that over the last, I'd say 3 to 4 years, I've had a whole sort of delving into that way of understanding health. And I realized we don't, it was new to me, and I don't think we talk like that so much. Probably everybody does in the health world, but not in the design world. I really don't think they do. And so for me, it's been a huge learning journey, and now I can't see things in any other way. And so for me, that would be one thing, is just how we communicate what we mean by health. And it's that quality of life, I think.
Yeah, before Pete says, I mean, what Lisa's saying is something I've experienced a lot. I actually think there's like a language breakdown between the planners and the designers, and the people in in the healthcare and clinical world. And it often strikes me that the one thing that happens to clinicians when they go into practice is they take something called the Hippocratic Oath, where they say, "I will do no harm." And somehow that has escaped a lot of the design and building community, and it might be a good idea to introduce that kind of thinking, if only to communicate between the two parties. Anyway, Pete, what do you have to say about inspiring developers when you invest in?
I think there's a lot of truth in that. It's still, if you ask a typical developer about health, they'll think, oh, you want me to fund a GP surgery. That's about the kind of the limit if you're not careful. So I totally agree. It's actually, I think a lot of actually developers are not fundamentally bad people. It's not that they go around thinking, oh, how can I ruin people's healthy life expectancy every morning. They just often don't have the awareness of the social determinants of health And then what we're trying to do at the moment, particularly working with people on the stage as LNG, is fund work that just gives a very simple playbook to, if you want to build healthier housing and healthier communities, here's how you can do it. So they don't have to start from first principles on that. There's actually kind of some pretty clear guidelines that we hope is something we can contribute to the wider development industry to help, as an industry, people produce healthy homes. All of that said, I'm not one of these people who thinks, I'm a rampant capitalist and this is all going to somehow be done by the market. There is a need for the right type of regulation, because there will always be laggards who won't play by the rules and will then try and undercut people in the land market who are seeking to produce generally great outcomes. So it's that combination for me of enhanced regulation where that's appropriate, but also really trying to just make this simple for people to do the right thing.
I mean, does health play into the ESG agenda? Do people in the room here know what ESG is in the private sector? It stands for environmental, social, and governance. And it's a way that a lot of industry self-regulates in this area, and it's driven very much by stakeholders and shareholders who want to see their funds stewarded and invested in projects that deliver those principles of ESG. So I'm curious, do you think we need to add H to ESG?
We have to. So at LNG, we call it ESHG. We already put the health in there. And that's come out of a lot of work we've done with Sir Michael Marmot around the role of industry and business in tackling health inequality. But yet, just a recent example is we got into a bit of a fight with Sainsbury's, the supermarket, because they weren't paying their workers within London the London living wage. They were seeking to move, and they kind of said, well, no, we're a profit-making entity, we can't afford to be paying these people. And we said, we're one of your biggest shareholders as Legal and General, and we want you to be paying people a London living wage, because we're not, when we're asking you to maximise shareholder value, we're not asking you to maximise it on the backs of reducing health inequality, which is what not paying London living wage leads to. So that was in the public domain. There are others that obviously I can't talk about because we've chosen to keep them out of the public domain and solve them amicably. But that's a good example of us as a major investor in companies putting health right into that ESG mix.
Great. So I'd like to move on a little bit to health facilities themselves, and how hospitals and health facilities within the NHS estate and beyond can actually lead by example on this discussion, and actually serve as leading examples of placemaking, community spaces, public realm, supporting wellness activities, et cetera, et cetera. And I've got no better an expert than Magali to my left, who does this for Great Ormond Street Hospital. So maybe you can share a little bit about hospitals and healthcare spaces can lead by example.
Thanks, Claire. Yeah, so at Great Ormond Street, we've been working on a concept for a healthy hospital street. And I don't know if you're familiar with Great Ormond Street itself, but it's like many London hospitals, I would say, in that it's a noisy and congested street. The air quality levels go over the World Health Organization limits daily. There's very little contact with nature, very few places to sit, no access to water fountains, fairly basic things like that. In terms of, in relation to Great Ormond Street specifically, obviously children are particularly vulnerable. So part of the sort of argument for addressing the street, even though it's beyond our boundary, was that there's no point treating children, I don't think, for things like respiratory issues in the hospital if they step right onto a super polluted street as soon as they leave. And part of that, I think, is also it starts to sort of lead you towards more of a preventative approach to health, and also responsibility in terms of our patients that goes beyond our walls. And in fact, I remember talking to someone saying that actually each child's visit to the hospital starts when they open an envelope, when they open the letter or the email telling them they have an appointment. So it's actually looking well beyond our walls and to the journeys that come to the hospital, and also looking at the perspectives, different people's perspectives. So we've also done an exercise recording the journey from Russell Square Tube to the hospital 95 centimetres above the ground, which is the average height of a 3-year-old. And it's just really interesting to view that video from that angle and see that child basically saw the backs of cars, the backs of people's bags, a very grey, sort of joyless environment really on their journey there. So I think that's kind of a brief description of what we're doing there, and we now have a concept for a much healthier greener, joyful experience for the street.
Thanks. And I'm going to ask Lisa to comment on this because, you know, you've been talking about this idea of a health street, a place-based approach. And, you know, coming from a leading design studio, it'd be really interesting to sort of hear what Magali has to say in your comments on how you can take some of the examples that she's reflected on and how those might be integrated into your designs.
Well, one of the kind of starting points of thinking about a place for health or a health street was really a seed space, a space where people could come and understand their health better. But we were thinking about the physical environment of that space. And as a studio, we've had the fortune of designing a Maggie Centre. So that's a non-clinical centre for support with cancer. And the design brief for that building is incredible because it's all about emotion. It's not about square meters. It's not about areas. It's just about what people should feel when they go in. And it's really interesting to see the kind of outcomes, the really broad range of outcomes and the freedom you have when it's a non-clinical space, but it's driven by emotion, and the idea of hope. And I think we thought, what would a space like that be? What would that be like if you could have a space that was equally hopeful, but about health creation, and you're in a sort of different frame of mind in a way to think, right, what am I going to do today to improve my health, or how can I think differently about health? And you know, some of the spaces that we experience, and this idea was really a space for the high street. You know, retail environments can be anything and everything. You know, there's absolute freedom of what you could do. So there's no reason why a space on the high street could not be really inspiring and have natural materials and have nature in there and all sorts of things, and also be flexible and changeable and accommodate different organizations. And so we were just sort of imagining a space like that which I just don't think you get on the high street. You get very, very similar kinds of retail organizations or empty spaces or community organizations doing things on an absolute shoestring. And so, you know, how could we get a really inspiring environment? It doesn't have to be that big, but it can enable a lot of health-generating activities to be right on the street. And the design and feel of it is really important, the emotion that you get from that.
Has anybody in the room been to a Maggie Centre or seen a Maggie Centre? How many are there?
I think there's about 26 now.
Right.
And they're now being built internationally, but they're not big buildings at all. So, you know, they're about 500 square meters, but each one's very, very different, but it's all about the experience from the first time you would receive a diagnosis. And I think what's interesting is they're on NHS properties, so they're on NHS estates, but they do not feel clinical in any way. And it's, you know, taking that logic, and it's interesting how that such inspirational design for uplifting experiences has come from some of the most acute, you know, medical experiences, and it's come from there, but it could be totally applicable to kind of health creation.
No, they're very impressive. I think the closest one in London is Charing Cross. Is that correct? Outside of Charing?
Yes, yeah, this one.
Yeah. Well, since we're at a health tech event, I would be remiss if we didn't talk about data. So I want to ask some of our panelists about, you know, how do we use the wealth of data in local communities? And by that I mean on demographics, on participation in active travel, air quality, green spaces, some of the things our panelists have talked about, together with the evidence on health impacts from the built environment, on outcomes such as cancer, diabetes, obesity, et cetera. How do we use this data to actually develop local health strategies and interventions? And I'm going to ask the first person to comment to this, Michael, coming from the Department of Health. Please welcome your thoughts.
Thank you. Hello. I get asked the question all the time by local authorities wanting to use data better. And I think, firstly, the way that we use data in public health isn't useful as much to the built environment sector. In public health, we tell our stories, we do a lot of graphs, but actually for town planners, we like maps and things like that. So people can tell us exactly where things are, where things should be. That allows town planners to take action through policy interventions, through active travel, green space provision, affordable housing, whatever it may be. So I think firstly it's about not maybe having more data, but presenting data in a very, very different way. So in a way, we need to look at our JSNA in a different way, and there's no strict guidance about what JSNA could be presented as locally, but there's ways that councils, actually like Tower Hamlets and other areas, are having a spatial planning chapter of the JSNA to really dig into the kind of environmental needs assessments, if you like, of their communities, and that in turn informs local planning policies for the next 10, 15, 20 years for new housing development. And there are ways to do that. So Oxfordshire, for example, Wakefield, they have in their kind of health impact assessment, guidance, in each ward, they have these priorities around health, whether it be respiratory disease, crime prevention, whatever it may be. And when you're a developer going into the area, developing new housing in that area, you look at those priorities. So immediately you're just presenting data in a different way, spatially, so that we can take action. And that's how we kind of promoting the approach to local authorities. Thanks.
And Natasha, how did you use local data to come up with the metrics and the predicted outcomes around the health and wellness strategy in Brent?
So what I've done is essentially make a new requirement for developments to look at the data in the first place, so that becomes the starting point for design. So you'd have to, say you've understood what is the context. Is it a context of deprivation or child poverty or lack of green space, lack of open space, whatever that is. State how that's been understood and how that's being responded to as part of the design process. And I think the opportunity with data is to make that more accessible, but make that just a normal thing that happens as part of how places are designed. So it's like the baseline starting point is people's needs in that place, really. So, yeah.
So I'm going to ask another question of our outstanding audience. Does anybody in this room know what a blue zone is? Few people know what a blue zone is. So if you're watching Netflix these days, there's a heavily streamed program called Secrets of the Blue Zones, and I think it's prefaced with how to live to 100 and something about longevity. But the point of it is it's all about places around the world where people do live long and very flourishing and very happy lives. And the presenter goes through with, a forensic level of detail, what are the contributing factors to why these places sustain such a long and healthy quality of life. So when this panel first got together, we did have one initial discussion, and we all sort of thought, maybe one of the missions of the new structuring of the NHS, which is very place-based, as we've been discussing, maybe the incentive should be to create blue zones. So I thought each of us would have something to say about that, because there are these number of social determinants and other contributory factors. So I'm going to start with Lisa, and we can maybe move around. How do you think in designing a place the blue zone principles are helpful and informative and may actually drive engagement and success ultimately?
Well, one of the things I thought was really interesting about the documentary series, and they go across different parts of the world, but they sort of all have certain commonalities, and one is that sort of physical activity is just built into the everyday. And I always sort of wondered about, and a lot of the examples are in warmer parts of the world, but I always wondered about what could we do about being more active in the winter when it's cold and dark in this part of the world. And I think some of all the really good habits that we do just disappear at this time of the world. And what could the built environment do to enable that? Very simple things like floodlights in parks. I mean, it's just like an absolute shutdown in the evenings. And you go to places like Norway where it gets really dark, and all the outdoor spaces are floodlit, because they have no other way of existing. And I think the difference to our relationships to being outdoors and in being more active would be facilitated by very simple things like, the extent of outdoor lighting in the winter and things like that. So that was one of the things I took of like, I loved all the examples, but I couldn't see it applying to where I was in London or where I'm from in Scotland. And I was thinking, how does that work in our climate? And I'm thinking, well, part of it would be how do we be outdoors for longer? And that was one thing.
So, Pete, would Legal in General have the qualifications around blue zones as a driver for investment?
There's probably a more important driver for investment, which is around meeting the social need, and that's and making sure we're clear on the outcomes that the investment is driving, and that is actually in the investment proposals that go through the committees. So yeah, that's all about trying to really track what difference will our investment into Bristol or Newcastle or whichever city we might be investing actually lead to, and how can we audit that over time. I think my takeaway from this would be around planning, actually. The UK is still firstly, just horrendously under-resourced in terms of our planning system. But secondly, it's still far too ad hoc. And if we can get to the point, and some of the announcements coming out of Labour have been quite encouraging around this, I think, recently, where we have a far clearer plan-based plan that enables us to put in the kind of measures that we're talking about here. It also removes the current system where people will be promoting land for new towns or new developments, and all of the value uplift goes to the land promoter, which then means there isn't enough value to build in the kind of infrastructure we're talking about. So this might sound like quite a techie financial answer, but it's actually fundamentally at the root of a lot of this. If we can get to a point where we're planning very clearly where new towns will go, the land goes in at a more sustainable rate, that gives more value uplift to put in the kind of resources that we need to create healthier places. So actually kind of being clearer strategically on what our plans are, where new settlements will go, where new housing is going to go, and then in return for reducing that planning risk, being much clearer on what we need from place creators, developers, local authorities, on how they can create healthier places. That would be a real recipe for success, I hope.
And Magali, do you think that a hospital environment can promote prevention and promote the blue zone principles and lead by example that way?
Yeah, no, I do. I mean, I was going to comment first. I was struck by watching the blue zones. One of the things that there's a big focus on was sort of retaining meaning in your life as you get older, and the importance of company, and not being lonely, and what isolation can do to you, which again touches on the Chief Medical Officer's report, I think, in terms of ageing populations. And one of the consultation events we did recently at GOSH, I spoke to a local older person who said they had essentially recently moved a bus stop from one side of Euston Road to the other, and that meant that her elderly friend who visited her once a week no longer could. It suddenly made that journey just not plausible for her, or too far, or too difficult. And it just really struck me how these small things that we maybe do without necessarily thinking of the implications can have such a big effect on people. And in terms of health facilities, I think I'd love the idea of hospitals being, I think in Sydney they're designing a hospital at the moment where the ground floor is just completely open to the city. It's like a public space, if you like. And I think that would be wonderful if ground floors could actually be spaces for health, for yoga, or for eating well, or for meeting people. So nothing to do with illness, really, and maybe the other sort of elements of the hospital could be above that. But that would be, yeah, it's almost like a campus of care. That would be what I take out of the blue zones and what I'd like to incorporate.
Does anybody else want to comment on blue zones before we move on? Natasha, do you have anything you want to say? You kind of are trying to create one in Brent.
I think
Never thought I'd say London Borough of Brent and a blue zone in the same sentence.
As a resident,
I think everywhere should be a blue zone. Is my thought.
So I think the final point we're going to discuss before we throw questions out to all of you is, again, in our sort of pre-panel chat, we came up with the idea that maybe one of the best interventions could be the creation of a fund to support developers, to support local authorities, to support all stakeholders in placemaking, a fund to create health. So we call that the Health Creation Fund, with guiding principles to actually act out some of the examples and initiatives we're kind of talking about. And I'm going to ask Michael, as the Department of Health, do you think that's feasible? Do you think it's doable? And do you think it's desirable?
I mean, we already have it in the planning system. So we have developer contributions where developers pay, money in terms of site-specific mitigations. And actually, the value of that in 1 year was £7 billion by last government research. And £7 billion is quite a lot of money just for the planning system. A lot of it goes to affordable housing, but some of it goes to green space provision, play areas, recreation. So it's about being explicit about meeting those objectives around health and those, that £7 billion. And meeting them where people need them, like in the north, where the value is slightly lower than in London. So we already have it. I think it's more about what developers would like to fund and what communities would like developers to fund. And it's where social value conversations comes in. But I do agree with the principle that there's something already in the system currently.
So I'm going to ask Pete, if there was a health creation fund and this kind of overrode the patchy, if I can say that at best, network of Section 106 payments and community infrastructure levies, do you think that would actually help guide a lot of your investments? And do you think it would bring more developers into better placemaking?
I have to admit, I agree with Michael on this. I'm always against the marginalisation of specific social interests by creating a fund for them. I've spent most of my career battling to make sure that things we care about are in the mainstream rather than marginalised by putting them into one fund off to the side, because the risk of that is then you make all of society's finance and say, you guys don't have to worry about health, you're not the health creation fund, that's the health creation fund. So I think people should be challenging their pension provider and saying, what are you doing to create health with my pension, rather than putting it off to one side.
Good answer. Okay, we have just a few minutes left. Are there any questions from the audience that you'd like? Is there a roving mic, by the way, or for? Yeah. Oh, yeah, you can use one of those. Okay, sorry. Can you put your hands up again?
Oh, hang on. We got loads of questions. Right now, we're up against the buffers of time, Chair.
Okay.
So we're going to have to ask you to keep it brief, and we'll take. We got 3 questions. We'll take the 3. Okay, where you go.
Quick. So a question is, if investors, developers are not evil, but they are driven by profit, and incorporating health initiatives will ultimately cost them more money. And can we do it without regulations? That's the first question. And if not, what is actually going on with regulations? Are we doing any work on that front?
Back to the old 106 agreements.
Yeah, exactly.
Yeah.
Well, Michael, maybe you might be... Oh, I see. You want to ask...
Start answering that one.
Okay. Maybe, Michael, you can comment on that, and then we'll come to the next question. Yeah.
Okay, fine.
Hello, my name is Rumbi. I am a doctor, a GP trainee more specifically. So for me, I think opening a GP practice partnership is something I'll aim towards. Any advice from you guys on serving the population and how to build a practice from scratch, which incorporates some of the principles that you've talked about?
Are we going to see GP practices built anymore? They're all vertically integrated into hospitals, aren't they? Are they going to be?
Yeah, well...
Is it still a proposition? And there was one more. Yes, ma'am, I'm coming.
Yeah. I think we're just going to start with your question.
If you don't, I'll take the third, and then you take them all. Yeah.
Okay.
Hi, so this is specifically a question for Lisa. I'm not sure if you guys have touched on the new hospital program, but I was wondering how you see the tension between, I think, a lot of government to push to use modern methods of construction, MMC, versus what we understand to be good design principles, like using natural materials or being site-specific. So how are you getting involved in the NHP, and what are your thoughts on that?
Okay, so I think we'll start with Michael for your question initially.
I mean, I would just say, I mean, regulations can only go so far. And actually, sometimes when you do change a design, it doesn't cost any additional money. And there's plenty of examples I can give you. If you do X, you don't actually need additional money. As long as you get into the system early enough, developer can change their plans quite early and quite easily without having to cost any more money. And at the end of the day, they know what makes them money, so they can't do as they will obviously negotiate with you. But I would just say, get into the conversations early, and they'll be able to change the designs without any additional costs.
I think Pete's going to comment on that too.
So I think I was clear. I do think you need regulation. But despite that, one of the big things for me is it's actually far from just a matter of arguing about Section 106s. A lot of the things we're doing aren't costing us a huge amount of money, if I'm honest. It's just being really intentional and thinking quite carefully about the design, or particularly how you then manage and steward the homes. So, for example, offering people access to affordable healthy eating programs. It doesn't cost L&G a huge amount, but it really does move the needle in terms of health outcomes. So, but it's just the kind of thing developers typically won't think about. So that's why we're doing a lot of work at the moment with people trying to just provide that playbook to try and make it easier. But I'm definitely not saying leave everyone to it and they'll all produce brilliantly healthy towns. Regulation is going to need to come in as well.
Okay, and then on the question about the GP, I think Magali is going to make a comment coming from the point of view of an NHS trust in Great Ormond Street.
Just in terms, I think you were asking about setting up a GP almost from the beginning. I think that's really exciting, a massive opportunity. I think one I would maybe use as a reference study, there's a Bromley by Bow Centre, which you may know, where there's a lot of, an approach to preventative health, and a much sort of wider understanding of what health means. So that's my comment.
And I think I'm under the gun. So the final question was, I think, directed to Lisa, and
was,
maybe you can comment on that.
I'll see if I can answer it. So I think it was to do with the conflict between modern methods of construction and the sort of program to build new hospitals versus actually what, using really interesting natural warm materials. So I think, that's a challenging question. I think there's always a demand. If you can build more space that treats more people, there is much more sort of priority towards that to some other priorities, such as the sort of materials. But there is a trend now for certain activities within hospitals that don't need to be in them. They can be taken out of hospitals to free up spaces. So, there's a sort of wider question of how many hospitals do we need to build? How much do we need to restructure what is in hospitals and what comes out into community spaces? There's a project that I've been involved in where diagnostic centres have come out of a hospital. They're going into a repurposed shopping centre, and it can kind of create a different kind of experience. So I guess it's a larger question of what has to be in hospitals and what doesn't, so that you can take non-clinical things out.
Great. So I'd just like to say thanks to our panelists, Michael, Natasha, Lisa, Pete, Magali, and from me, Claire. Thanks very much for coming. It's been a really interesting conversation.
Ladies and gentlemen, thank you. That was really very interesting. Thank you all very much.